of time, so I just want to let you know that he was originally trained as pediatric intensive care medicine in Stanford University, and he was served as a director of integrative medicine and pediatric intensive care, where he created the first holistic intensive care unit in 2005. It's difficult to talk after a few wine, probably. In 2007, he started training with the co-developer of the Endobiogeny teacher, Dr. Jean-Claude Lapraz. What's his last name? Lapraz, is that correct? And he's the president and the co-founder of American Society of Endobiogeny Medicine and Integrated Medicine, and medical director of Full Spectrum Health Center for Integrated Medicine. He also conducted lots of research, which I had the pleasure to work with some of them, including evaluating heart disease using the biology of function. I really recommend everybody look at the biology of function. I find it just fascinating field about how to approach all of our diseases, and it's just amazing about this biology of function. Just wonderful. He's also developing a proof of concept study for prediction of disease in infants based on biomarker testing of the cord blood. And he also, of course, has a fellowship in this area that's running in US and in France. And it's really my pleasure to introduce Dr. Hedayat, not as just a great doctor and scientist, also as a good friend, and just amazing doctor. Thank you. Thank
you. Well, I want to thank you all for coming, and I want to thank this august institution for supporting all the Iranian speakers and thinkers, and for graciously inviting me to come today. I'm truly grateful to have the opportunity to share this work with you. And of course, like any great work, it was the labor of many, many people, both openly and behind the scenes, and I'm so fortunate to have two of my co-authors in the audience today. I'm going to be presenting a discussion of our first clinical study ever to be published in Endobiogeny. It's called The Novel Use of Biomarkers in the Modeling of Cancer Activity Based on the Theory of Endobiogeny. Our lead author was Dr. Buehning, who's here today with us, and Dr. Gulshan is here, of course. And this will be published next month in a few weeks in Global Advances in Health and Medicine, GAHMJ journal. Yeah. So, you know, I am not a smart researcher like most of you here in the audience. I'm just a physician, and I'm just a clinician, and like the founder of Endobiogeny, who was a general physician, what the system that he created, Dr. Durfour, and what I'm going to present to you today is really because he saw what everyone else saw, but he came to different conclusions. So really, because Endobiogeny, it's 40 years old, but it's new to most people. So I'm going to give a brief discussion about cancer, which I know is very basic for most of you here. But then I'll talk a little bit about Endobiogeny, about the biology of functions, which is the modeling system using a systems biology approach to biomarker analysis, and then we'll discuss the actual data and come to some conclusions. So, what is cancer? I think for this audience here, you all know that cancer is a dysregulated cellular growth. But if cancer was simply dysregulation at the cellular level, then destruction of abnormal cells by chemotherapy or radiation or a surgical removal of the cancer mass would have cured every cancer every single time. But that's not the case. And if we say that, okay, well, it's dysregulated cellular division, so all we have to do is block mitotic activity and we'll cure cancer. But we found that that wasn't the case either. And what we see is a trend that while short-term survival is improving, and some cancers, definitely the rate of mortality has been reduced, but overall we see that there's more and more cases of late onset cancer, and they're occurring in younger and younger adults as well as in children. So from the perspective of endobogeny, we argue that there needs to be a different way of looking at cancer, which does not reduce the human being to the level of the cell or subcellular mechanisms of replication or survival, but contextualizes the cancer within the global systemic activity of the human being and the global physiology. When we think about ways of diagnosing cancer, there's a number of unifactorial approaches that have been taken. So you can take a structural approach, such as a mammogram. This is a MRI of the frontal lobe, an astrocytoma. You have some functional studies. This is the PET-CT scan, so it's looking at the metabolic activity of the cancer, of a tumor. And then we have thermography and ultrasound as well. So there are definitely some advantages and benefits to using these types of unifactorial, as I call them, diagnostic approaches. You can get a sense of the location of the tumor. You can get a sense of if it's impinging on some type of vital or semi-vital structure. You can look at metabolic activity. But how do you understand why this cancer came about? What were the factors that actually are driving the growth of this cancer? These types of tests will not answer these questions. Now there's some other approaches which start to become more sophisticated. So for example, you can do a classic histologic analysis. You take a biopsy, you stage the cancer by the location that it was initially discovered. And then there are protocols that are based on where the organ of origination and how far away it is from the organ of origination. Then you have more sophisticated studies that can be done, such as circulating tumor cells. And we had an excellent presentation, I think, just about a year ago now. Is that right? On circulating tumor cells. Then there's a more complex oncobiologic approach. This is a survivin protein and apoptosis regulation. And then you have other studies such as telomerase and immortality and looking at telomere length. Shortcomings, again, they're unifactorial. They're looking at the cancer in isolation of the global physiology of the human being from which this cancer came from. I mean, cancer is not something that you swallow by mistake. It's something that comes from the human being within the context of the global physiology. It's a reactive modality because you have to wait for the cancer to occur. So you're always reacting to something rather than anticipating. And there's a certain lack of a predictive assessment with respect to who has a tendency to develop cancer, who has a risk of a recurring cancer, and what is the rate of evolution of the cancer in the person. And as I mentioned, it does not determine causative factors because it's focused on the downstream cellular and subcellular physiology rather than the upstream regulators of cellular function. Now, in the last few decades, there's been development of multifactorial diagnostic approaches as well. So we have hematologic studies that are still in investigation. So here we have DNA methylation patterns, and these are basically pieces of DNA that can be picked up from the blood and evaluated. We have microRNA, microarray PCR that can be done. And this study here is looking at, let's see, this is, I think, a metabolic study, and it's typing the cancer based on the type of metabolic activity it has compared to a normal associated tissue. So from the perspective of endobogeny, there's certainly some promise in these multifactorial approaches because they reinforce the concept of cancer as a complex multifactorial disorder. They're nuanced, they're sensitive, they're specific, and they're more individualized than some of those early unifactorial studies that we mentioned. But again, they still reduce cancer to a strictly cellular phenomenon, so you're looking at cellular metabolic activity. From our perspective as clinicians, what's needed is an evaluation of cancer as a systemic disease expressed at the cellular level, and that requires a global systems approach. And And that's where I'd like to transition to introducing you to the concept of endobiogeny. So we have, in medicine at this time, and we have many excellent centers of integrative medicine and holistic medicine here in San Diego that are proposing different ideas about how we understand the world and how we understand the universe and human beings. And there's a false dichotomy that we have to choose one approach over another. We have a reductionist approach, which is quantitative in nature, so it measures the number of items, it looks at the function of the parts, it's hierarchical in nature, it's categorical in its conclusions, it separates things rather than being inclusive, it looks at things as independent variables, it tends to look at ideas or events as static events, and it seeks to control. And then we have a holistic approach, which is qualitative in nature. So rather than looking at, say, how much of something, it asks how well is it functioning given other variables. It looks at the function of the entire system. It looks at relationships, so it does basically relationship analysis. It's individualized rather than being categorical. It looks for the connections and sees how one function affects other functions, either directly or indirectly. It looks at interdependence. As the Buddhists say, happy Interdependence Day instead of the happy Independence Day. It looks at systems in a dynamic fashion, and it feels comfortable with creative chaos and spontaneous communication and self-organization. Elements that have an interest in working together will spontaneously develop through, for example, electromagnetic wave communication signals. They will develop coherence, kind of in a hive mind or a swarm mentality. Well, for those of us trained in the scientific tradition, it's hard to accept the relativity that the holistic approach offers. And you know, there's good reason for us to say, do I have to give up everything on your left to take everything on the right? Because when everything is strictly qualitative, I mean, if you ask a cancer patient, how do you feel today? And use that in place of a PET scan, it's really not an appropriate way to determine what the nature of the cancer is and how the patient is dealing with the cancer. But if you say, I don't care how you're feeling, I just want to know how active your cancer is, that's also not really something which situates that cancer into the human experience that the individual is experiencing. And what we say in endobogeny is that this is a false dichotomy, that we have to have one or the other. Because everything in the universe, from the level of the cell to the human beings, the human societies, to planetary movement, to universal forces, they all function under both levels at the same time. They're describing different levels of reality. When you ask one type of question, you go on one side of this column. When you ask a different type of question, you go on the other side. And when you want to know something that's closer to reality, you encompass it all, and you take in all of it. And that's what we do in endobogeny. And I'll explain a little bit about that shortly. Endobiogeny is a theory of terrain. Terrain is an old European term, maybe from about 120, 130 years ago, that was developed to describe how cellular physiology works. And the idea that it's like the terrain that we survey. From the specific aspect of endobogeny, the theory of terrain is the sum of all the factors that ensure the structure and the function of the organism. So here, structure is referring to the cellular elements that allow the cell to maintain its physical apparatus of existence. So the DNA, the nucleus, the Golgi bodies, the ribosomes, the enzymes, the membrane proteins. These are all aspects of structure. But we also look at function. Function is how the cell adapts itself for its own cellular metabolism, and how the system, how the human being as a whole adapts itself to external and internal aggressions. The theory of terrain in endobogeny also looks at the genetic heritage and it looks at the adaptive capacities of the organism, as I mentioned, against both endogenous aggressions, like a tumor, as well as exogenous aggressions, like trying to get here on time for this lecture and fighting traffic. So it really encompasses everything from birth to cellular function to adaptation. So if we accept this idea that the terrain is what we need to understand, the terrain is basically the sum of all the factors: genetic, environmental, basic structural, endogenous activity, and functional activity. We have to ask ourselves, what manages this terrain to ensure that we come into existence and we stay alive? Whatever this manager is, from the perspective of endobiogeny, needs to have ubiquitous interaction with every element of the human body, right down to the subcellular level. It must constantly be in interaction with these elements, and it must be able to regulate itself as it's regulating everything else. From our perspective, the endocrine system is the only system that meets these criteria. And therefore, the endocrine system is the manager of the terrain. And therefore, to properly study the endocrine system and the role of the autonomic nervous system to stimulate and calibrate and refine the intensity and duration of endocrine activity is to understand how the body functions. Endobiogeny is not just a theory which has been developed in some university. It was developed by a general physician in general practice in Paris, France. And so it is a very practical system that is used every day around the world. Just to talk a little bit about the clinical approach in endobiogeny, when we evaluate somebody's illness, be it cancer or anything else, we look at the etiology, the rate of development, and the invasiveness of the disorder. We look at the patient as a whole, and we say, what is their reactive and adaptive capabilities to deal with this illness? We look at the endogenous pathologic causes, which can include genetic causes, and we look at the evolution of their terrain over time. So for example, the last case that I saw before I came here today is a 44-year-old woman. She doesn't have cancer, but this idea of the evolution of the terrain is what's relevant here. It's a 44-year-old woman who presents with a functional infertility, and she has hypersensitivity to food, she has poorly formed stools, she has chronic fatigue. She was born to a mother with major depressive episode, undiagnosed, untreated, and she had a narcissistic father with rage issues. And she grew up in this household. Her parents divorced when she was 6. She had no memories before 5 years of age. She had a series of other events. She was date raped twice within a 2-year period of time. She was 10 years ago, she traveled to India. She got sick. At that point, her terrain had evolved to the point that it was not able to handle the illness that she acquired in India. And that set off a whole series of events that over the last 10 years has resulted in her seeing me. This is just an example of what we mean, of the evolution of the terrain over time. And then we look at the combination of the illness and the patient. What is their degree of coexistence? With respect to cancer, this is a very relevant situation. Those of you who work in clinical medicine, I'm sure you know that, especially in perimenopausal women, for example, many times they will be in a certain state of developing a cancer which will go away as they enter into menopause. And a lot of times there are false positives that get picked up because of a mammogram or some other type of evaluation, and there's no sense of what is the degree of coexistence. I mean, you can't know. By the current standards of evaluation, you see something questionable on a mammogram, you have to act, you have to do a fine needle biopsy, you have to do something. Because you don't know what is the degree of coexistence. What are the various tumoral factors, such as the degree of apoptosis or the rate of necrosis or the level of interleukin activity for surveillance against tumors, that this patient might be expressing in their terrain that allows this tumor to coexist with the patient at a very early stage of development. In fact, just something I'd read by one of our friends who is a mathematical biologist, he had written how over 100 years ago, surgeons in Europe had done some experiments where they found that if there are two tumors in the body and you take one out, the other one will predominate and would kill the animal. And that the two tumors would create this sort of turf war that would allow neither one of them to actually grow and kill the animal and would create this state of coexistence. It's just a little example of what I'm talking about. Then there's a relative level of structural versus adaptational activities that the organism goes through and the domination of the dominance of one over the other. So when we look at, when we look at integrating physiology, we start with a very basic concept that I'm sure all of you are familiar with, that the essence of life is metabolism. And metabolism is divided in its most basic state into catabolism and anabolism. And that this is under the direct control of the endocrine system. So from the unicity of metabolism arrives this dualism of catabolism and anabolism. And from this dualistic perspective, we develop a multiplicity of sets of related activity. So we have the corticotropic, or as we say, the hypothalamic pituitary adrenal axis, which is catabolic in nature. We have the gonadotropic axis, which is anabolic in nature, estrogen, testosterone, etc. We have the thyrotropic axis, which is again catabolic. And we have the somatotropic axis, such as growth hormone, insulin, glucagon, which is anabolic in nature. And then we have the role of the autonomic nervous system, starting with the parasympathetic system, alpha sympathetic, which then stimulates and sets off the chain of the general adaptation syndrome of Cellier, an expression of adrenaline, and back to the basal physiologic state of parasympathetic activity. And then from this general concept in endobiogeny of this multiplicity of activity, we come to something that looks like this.
Simple.
And this is a simplified version of it. The crown jewel of the theory of endobiogeny is something called the biology of functions. This is a quote from the originator of endobiogeny, Dr. Christian Durafour, and the co-developer of the teachings, and my mentor, Jean-Claude Lapraz. And it says the purpose of the biology of functions is to quantify the functional abilities of the organism before and after the effects of adaptation. Because the organism is in permanent movement, functionality can only be measured by a dynamic, integrated, and evolutionary methodology. Evolutionary here is referring to the ability to watch the organism evolve over time. So we need some type of objective system of evaluating human function, that's for sure. We need something that's objective, we need it to be quantitative, accurate, reproducible, and minimally invasive in order for it to be used with some degree of commonality. And this is why blood has been used for over 100 years. The disadvantage of using blood work as it's currently considered is that it's binary in nature. When a doctor gets the results of the blood test, he just wants to know, is it normal or abnormal? And each test is looked at individually as if it has no relationship to any other result. So therefore it has a reductionist approach, and it tends to create quite a bit of confusion between cause and effect in mechanism. The biology of functions is based on measuring the cellular elements that are generated from the bone marrow, because the bone marrow is the essence of life. So we look at the red blood cells, we look at the total white blood cell count as well as the percent differential, and we look at the platelets. So if you look at the 17 basic lab tests that we do, 70% of them are from the bone marrow. Because they also, or from the bone itself. So you have osteocalcin and alkaline phosphatase bone isoenzyme. And then 30% are other things. You measure lactate dehydrogenase, creatine phosphokinase. The ratio of LDH to CK is for us a marker of the functional metabolic effect of thyroid hormones at the cellular level. Because the roles of LDH and CPK in glucose metabolism and phosphorylation. And there's a number of clinical studies if you read our foundational paper that goes through that. And then we measure thyroid stimulating hormone. TSH is the only hormone that we actually measure. Even though endobiogeny is about the study of the terrain as it's measured by the endocrine system, we don't measure hormones in the blood except for TSH. Because what we find is that the serum levels of hormones are not indicative in a linear fashion to their cellular metabolic effects. And to measure, again, a series of hormones and consider them all to be acting individually without synergy or influence on each other is a concept which is not supported by the actual dynamism of the human organism. So we don't measure hormones. We measure the effects of hormones downstream through the output and change in these various cellular elements, and then in some cases upstream. So the biology of functions is about taking these biomarkers and relating them to each other through direct and indirect ratios. So if we come back to the discussion we had about the false dichotomy of a reductionist or a holistic approach, we see that we can resolve this dichotomy by saying, yes, we can use quantitative measurable biomarkers, but yes, we can look at the mathematics of relationships. We can see how they're related together in a truly functional and dynamic way. So an example of a direct ratio in the biology of functions is something called the genital ratio. This is simply the total red blood cell count divided by the total white blood cell count. And what this is looking at is the global tissue effects of androgens, which proliferate the number of red blood cells, in relationship to estrogens, which proliferate the number of white blood cells. Another ratio that you might be familiar with is the genitothyroid ratio. It also goes by the name the neutrophil to lymphocyte ratio. And I'll discuss this a little bit later in our talk. And then there's indirect ratios that get into much more complex relationships. So one example is the corrected genital ratio, which is the genital ratio times the starter index. And what this does is it allows you to start to look at the difference between the basal structural physiology of the body versus its functional adaptive capabilities. So now I'd like to discuss the study that we did with Dr. Buehning and talk about this case, and then I'll be happy to take your questions at the end. So we did a retrospective case control study looking at 92 patients in my practice here in San Diego. We looked at all types of cancers, both hematologic and non-hematologic or solid. And we did age and sex match controls in a 3-arm study where we had active cancer patients, people who were in remission, and then a control group. The biology of functions was available for all 92 patients. We pre-selected 62 of our 150 primary indexes that we felt had, or through our experience, we found to have relevance to oncobiology. Then we did a paired Wilcoxon rank sum study of active cancer versus control, and the remission patients versus control. And then we did an independent Wilcoxon rank sum to look at active cancer versus the remission patients. So these are our population characteristics. There was no statistically significant difference between either group. There was a wide distribution of types of cancer studied. And I know that in many classical or traditional biomedical approaches, this would have been considered a weakness of the study. But the goal of this study was to demonstrate that the endobiogenic approach looks at the basic biology of cancer. And for basic cellular activity and global systemic function, it doesn't matter what type of cancer it is. It does matter when it comes to treatment, and different cancers have different types of upstream neuroendocrine factors which drive their growth, that is for sure. But the purpose of this study was simply to demonstrate that the biology of functions and the theory of endobiogeny was accurate and valid in its basic conceptions, and would be able to distinguish patients who had cancer, regardless of the type of cancer, from survivors, from those who had never had cancer. So we found a number of the indexes studied to be statistically significant in this small study. The first one is called the beta melanocyte stimulating hormone to alpha melanocyte stimulating hormone index. The normal value is given here. There are no units associated with the indexes in the biology of functions because it's simply a series of ratios. So it's not milligrams per deciliter or picograms or anything like that. So this is looking at the relative level of participation of the beta and alpha MSH hormones in directly stimulating cortisol versus the general adaptation syndrome at the level of the pituitary gland. This becomes quite relevant because, as I'm sure many of you know who do work in cancer, both cortisol and thyroid can drive the growth of a tumor and can create a situation where there's what we call an escape phenomenon, where the cancer is able to escape the general regulatory control of metabolism. So the level of these hormones, beta and alpha MSH, are going to be relevant in manipulating or affecting the amount of cortisol output and thyroid activity. At the level of immunity, we looked at the pro-inflammatory index. Well, this was found to be statistically significant. It looks at the endogenous potential for inflammation, and inflammation is something that's been well studied and well documented to be related to cancer activity. With respect to anabolic hormones and the growth of tumors, we looked at estrogen fraction number 5 index. We looked at the comparative genital androgyny index, which is also found, these are all found to be statistically significant. And in the level of catabolic hormones, we looked at the thyroid index, which I mentioned is the ratio of lactate dehydrogenase to creatine phosphokinase. Then there's this index I mentioned before, the genitothyroid index, which is the neutrophil to lymphocyte ratio, which has been very well studied. We call it the genitothyroid index. It was actually developed by Dr. Durford in the early 80s. I did some research and I found that before 1987, there was only 2 articles published in any Western language that I could find on the neutrophil to lymphocyte ratio. And there have been over 400 published since the mid to late 80s. But he developed this in the early 80s as one of the first indexes he developed. And then we have a general look at metabolism with an index called the catabolism over anabolism index, which expresses the relative level of catabolic activity of the organism as a whole in relationship to its anabolic activity as a whole. So these are all the indexes together that I mentioned that were found to be statistically significant. You have here the mean score in all cases here referring to cancer versus remission versus control. So you see that as a whole, patients who either had cancer or were cancer survivors in remission had elevated estrogen activity relative to controls. And we found that the genitothyroid index, which is the neutrophil to lymphocyte ratio, was elevated compared to control. They had less androgenic activity than controls. They had more thyroid activity. That is to say, their cells were more sensitive to the effects of T3 and T4 on running cellular metabolism. And they also had a greater expression, relatively speaking, of beta melanocyte stimulating hormone in relationship to alpha MSH. They also were much more catabolic in comparison to controls who tended to be in the normal range. And their pro-inflammatory index was elevated compared to controls. All of this fits with what we currently understand about cancer physiology in general. Yes?
Not to be too quantitative, but how do you address the standard deviation being so large?
Because the question is, how do we address the fact that the standard deviation is so large for some of these, like the estrogen fraction number 5?
Moreover, further down, the metabolism.
The metabolism over anabolism index also has an elevated standard deviation. The way that I would address this is to remind you that this is looking at both solid and non-solid tumors. And as a clinician, in my clinic, when somebody comes to me and says, I have cancer and I don't want chemotherapy, or this is my second or third recurrence and I don't want, or they say I want support during my chemo and radiation, it is important to consider the specific tumor, and we have very specific paradigms of what drives the activity of specific tumors. So for example, a melanoma has a very different physiology from our perspective than does breast cancer. But breast cancer and colon cancer share more physiology than, say, they do with melanoma. So remember, this is just an all-cause evaluation. When we looked at just the active cancer patients versus controls, again, what we found to be statistically significant or bolded were 3 indexes, which was, again, the estrogen fraction, which had a mean value which is about twice as much as the controls. The thyroid index, which was elevated versus controls, and the beta alpha MSH. So you see that when we included the patients in remission, the beta alpha MSH index was actually normal, but here it's elevated because the active cancer patients have more expression of beta melanocyte stimulating hormone. So beta MSH, one of the things that it does is it directly stimulates the release of cortisol outside of ACTH feedback loop, and it also acts as a slow-acting stimulator of the thyroid to constantly release T4 outside of TRH and TSH regulation. When we compared, let's see, active versus inactive patients. Yes, so here we're talking about cancer versus cancer survivors. What we found was the genitothyroid index was higher. They had a lower genital androgen ratio, which would be like testosterone. Again, difference in thyroid activity. Again, the beta alpha MSH and the pro-inflammatory index. We were asked to do a subgroup analysis, which we originally didn't do because our numbers were so small. But our reviewers asked us to do a subgroup analysis of breast cancer patients alone. And again, from our perspective, it was no surprise to find that the estrogen fraction was significantly higher when we just looked at the active breast cancer. When we looked at active breast cancer and the survivors together compared to control, they had almost twice as much. Their estrogen fraction number 5 index was almost twice as high as the mean score. And then we looked at colon cancer in a subgroup analysis, and here we found that the statistically significant difference was in the level of expression of genital androgens. So what are the significance of these findings? Well, from our perspective, as I mentioned, this was really like a proof of concept study just to demonstrate that the biology of functions is a method of modeling biologic activity based on the concepts of systems biology, and that it could differentiate different levels of activity in active cancer versus patients in remission versus controls. From our perspective, while there's still a lot of research that needs to be done and presented for peer review, one of the potential advantages of using the biology of functions is the ability to look at root cause factors for each individual patient at the neuroendocrine level of what is driving the growth of their cancer. It also allows us, in a practical clinical sense, to follow the evolution of the cancer, follow their treatment, their response to chemotherapy, radiation, and surgery, and it allows us to offer a certain level of surveillance for cancer recurrence. I wanted to talk about, for a few minutes before I take questions, the genitothyroid index, which is, as I mentioned, this neutrophil to lymphocyte ratio. There's over 400 studies, as I've mentioned, that have looked at the neutrophil to lymphocyte ratio. Many of them, most of them actually have been in cancer patients. And it has been shown to be predictive of mortality and survival from surgery. And generally, the higher the neutrophil to lymphocyte ratio is, the greater the amount of inflammation and the greater the risk of death. So the problem, though, with the neutrophil to lymphocyte ratio when it's looked at, now it's great because it's a ratio, it's contextualizing neutrophils, lymphocytes, but it's only one index. And again, one of the things we try to avoid in endobogeny is to be too categorical. You don't look at one index and say, this is what's going on. Because, you know, in human physiology, one level of activity affects another level of activity. That's why we have meta-indexes and meta-meta-indexes. And so while the neutrophil to lymphocyte ratio is generally just thought of as a general marker of inflammation, what can you do when your patient has an elevated neutrophil to lymphocyte ratio? Really not too much. You say, okay, you have an increased risk of dying. I'm still gonna operate on you. This is just an example. I was just sitting at my computer and I opened up EndNote and I just typed neutrophil to lymphocyte ratio. This is just the first, whatever, 2 or 3 dozen studies that came up. There's a lot of work on it. So what is the significance of just this simple finding? Again, for those of you who are clinicians, you will appreciate how valuable it is to have something that can be derived from a complete blood count, a CBC with differential. In as little as 5 or 10 minutes, you can run a stat CBC with differential, and you can get the neutrophil to lymphocyte ratio. But again, what do you do with this information? Well, in the biology of functions, this ratio gets incorporated into the catabolism over anabolism ratio. Because the higher the genitothyroid, or the more neutrophils you have relative to lymphocytes, the greater the level of catabolism is relative to anabolism. And this index gets incorporated into the cortisol index, which looks at, it models the effects of cortisol when it's expressed during both basal activity and adaptation syndromes. And the cortisol index gets incorporated into the adrenal cortex index, and that gets incorporated into the metabolic yield, which looks at the global level of metabolism. And then the cortisol index is used to derive the somatostatin index. Because we know that from studies in human beings and animals, that when there is elevated and prolonged levels of cortisol, there's a suppression of somatostatin and the ability to control the growth of all physiologic activity, including tumors, and that this can herald an escape phase if other factors are also present. The adrenal cortex index gets incorporated into the histamine index. The lower the output of global adrenal hormones such as DHEA, androstenedione, cortisol, etc., the greater the expression of histamine is. And the metabolic yield, for example, just it gets incorporated into the ischemia index. So my point here in showing you all this is to say that from the perspective of endobogeny, very simple observations can lead to very profound conclusions and very practical considerations for the clinician to determine what is going on with my patient, what is the best way to treat them. So in conclusion, the theory of endobogeny offers a whole system approach to cancer, and the biology of functions, which is the systems biology approach to biomarker analysis, distinguishes cancer patients. In this study was found to be able to distinguish cancer patients from survivors and control. And we believe that future studies should look at a homogeneous group of cancer patients versus control to better characterize specific cancer types and subgroups of responders and non-responders to chemotherapy. So I started this talk with a quote from European scientists from the 20th century, and I'd like to end with this wisdom from Hatifa Esfahani, I was hoping my father would be here to read it in Farsi because my Farsi is not bad, but to read poetry is something I don't really have a talent for in Farsi. But you see that he says, چشم دل باز کن که جان بینی آنچه نادیدنی است آن بینی.
دیدنی است.
آن دیدنی است آن بینی. Thank you. You want to read it?
Sure. Yes.
Yeah.
چشم دل باز کن که جان بینی آنچه نادیدنی است آن بینی آنچه نشنیده گوشت آن شنوی آنچه نادیده چشمت آن بینی از مضیق جهات درگذری وسعت ملک لامکان بینی دل هر ذره را که بشکافی آفتابیش در میان.
Thank you. Okay, I'll take your